This conference will now be recorded.
Good evening, everybody. It's Rick Davis. I am leading the group tonight. It's quite a large session. We've already got 37 people in right now, and we've got a lot of people who need time, and we got 2 newbies. So I don't think I have a lot to say. I have to thank our sponsors, who are Johnson & Johnson, Bayer, Novartis, Foundation Medicine, Telix, Blue Earth, and Myriad. Hopefully we'll add a couple more when we get to GU ASCO. Oh, I do have something to tell you. ACCC, A and 3 Cs, is the American Community Cancer Conference or something like that. It's basically the organization that represents community cancer centers. And they sent out something today asking for their members to critique it. And it was a guide to germline and somatic testing. So I opened it up, and to my surprise, the first thing on the front page said metastatic prostate cancer. And I was like aghast, because germline and somatic testing is not just for metastatic men. It's for all men if they are of a certain risk. And germline testing isn't for all metastatic men. It's only for metastatic men who require germline testing as a result of what their somatic says. And I'm thinking, boy, they're sending this out to all their people and they can't even get it straight themselves. So I promptly wrote back to them with 2 citations from the NCCN guidelines, and we'll see where it goes. But it's just really frustrating when these organizations who hold themselves out as educators don't have the knowledge themselves, and a little bit pathetic. Dr. John, you put your email address in for just to the organizers. Was that supposed to go to everybody? If so.
Nope. That was supposed to go to Steve Lodge. Nice going, John.
Okay. Well, it went to the organizers. It didn't go to Steve Lodge.
Okay, I got it. I'll fix it. Thank you.
Okay. Now, gents who came in after 10 after, if we've got time, we'll get to you, but you've got to be in here in the first 10 minutes if you need time in this meeting. Sorry, but we have a lot of people, and them's the rules. So I'm going to start off with Greg Lashevsky, and I just better get spelling right.
You got it
yes,
right.
I got the pronunciation right, but yeah. I better get the where are you? I can't see where you went. Speak up for me. So there you are. There you are. So that's because I'm a big Arsenal fan, and they've had a succession of Polish goalies. So you know, when there's a Szczesny on there or a Fabianski, you learn pretty quick. Where you told us you were 58. Where do you live?
I'm in Yorba Linda, California, which is in near Disneyland,
yes,
Southern California.
Mm-hmm. Yes, sir. We know where that is. And we have a couple of people in Orange County, and we know some people. When were you first diagnosed?
Well, just to be clear, I know the name of this chat here, this group is really with cancer. I've not been diagnosed with cancer, but I've had prostate issues for 7 years, I would say. And as I was talking to a friend of mine who does a lot of research, he has a PhD and works a lot with prostate. He thought it would be good to come to this group, or there's another group Wednesday. So I'm just here for. I have some questions around surgery, around medicines and things of that nature. And I'm not sure if I'm in the right place for that, but that's essentially...
Not really, but you're welcome to stay. So
Okay.
that group, if you have prostate issues and you want information on surgery, on radiation, on treatment, the
Mm-hmm.
group for that is the low intermediate group, which is
Okay.
led by Dr. Mark Perlow, who happens also to be a Southern Californian resident, but a little bit north of you in Sherman Oaks.
Yep.
They talk about everything related to treatment if you are low or intermediate risk, which you won't know yet. Now, the Wednesday group is for active surveillance, which you may well be, and they will help you figure out your diagnosis. So please come back on Wednesday night. That is a great starting point for you.
Okay.
Everybody in this group was either high risk on diagnosis, metastatic on diagnosis, have recurrent cancer, or are metastatic.
Got it.
So we separate the groups that way, so you don't have to listen to these guys who are way too advanced, and they don't have to listen to you when they're sort of beyond that phase. So if
No
you
problem.
don't mind,
Not at
come on
all.
in, same time, same place on
Wednesday.
Wednesday night.
Okay.
The group will be led by Hugh Idstein, and we will definitely take care of you. I usually get into that group a little bit later, not
Okay.
right at the beginning, but you will see me at some point, and I will give Hugh and the active surveillance the pre-treatment. We call that pre-treatment active surveillance to distinguish it from people who have been treated and they're watching what's going to happen after treatment. Those guys usually would come here or low intermediate. So that's where that goes.
No
So
problem. Appreciate
and you are 1,000% welcome to stay, but I don't want to freak you. We don't want to freak you out.
it. Okay. Well, thank you. Thank you for taking the time to explain all that to me. And I will be there on Wednesday. Have a great meeting, gentlemen. And
Thank you.
nice
See you
job.
Wednesday. And then on Wednesday, we'll tell you if you need to go to low intermediate. The next low intermediate meeting is a week tonight in this room at this
Okay.
time.
Okay. Thank
Okay.
you. Thank you. Have a good meeting.
Pleasure.
Thanks.
Thanks for coming
Bye-bye.
by.
You bet. Thank
Okay,
you.
Michelle, you did not get to hear all these questions, so that's okay. But we will work with you on behalf of your dad. And let me just say, we are really delighted to welcome you. We love having care partners in here. And before I forget, we have a care partners meeting. It is at this time tomorrow night in this room, and it's to support care partners of people who have been diagnosed with locally advanced or advanced cancer of any type. So, but there's a lot of prostate people in. So, would you like to tell us your dad's name, or how do you want to approach this?
I don't know. I didn't actually expect to be like have a spotlight put on me. I also didn't expect to be the odd one out to this extent in this group. But happy to be here. We are very. My dad's name is Detlef. He was born in Germany. He goes by Det, DET. He is 69, turning 70 in March. He does
Okay.
not know I'm giving his information away to all these strangers, but I'll tell him eventually and he'll deal with it. We got this is very, very recent. We got the news that he had cancer at all on December 3rd of last year, and we found out the extent and the stage of it this past Friday, actually. So
Okay.
it
So
is metastatic.
let me ask you a few questions, and then we'll be more organized, and then we can really help you. Where
Great.
does your dad live?
We live in Winnipeg, Manitoba, in Canada.
Ooh, okay. I say ooh because we've had a bunch of Canadians in here, and it ain't as easy in Canada as it is as it is here, and you're probably finding that out. But we can certainly navigate you and guide you. Um, so your dad was diagnosed 12/24, and I'm assuming he had a. What caused him to be diagnosed? Was he symptomatic?
No, completely asymptomatic. He got a, I don't remember how it started, but his PSA was 14, which is obviously higher than it should be. So that rose some red flags. He did a prostate check just at the doctor's office. They felt a nodule, so he went for a
Okay.
biopsy. They took 14 core samples, and 10 of those came back as a Gleason 5. The other 4 were Gleason 3. So we're looking at an 8, but basically a 10 with how many 5s those there are there. Um, and then there was Christmas. We had a long wait time. He did a CT scan, a bone scan. Those came up completely clear. So we got some false hope there. And then they ordered the PSMA PET scan, and that obviously did not come up clear. They found metastasis on one lymph node, his pelvis, his hip, his rib, his sternum, and his right arm. So
Pelvis, hip, sternum, and his right upper arm.
I believe so, yeah.
Okay. Um, okay. And what, which hospital is he being treated at?
Good question. I don't know.
Okay.
I will be going with him to his medical oncologist appointment. He hasn't started treatment yet since we only just got his staging.
Yep.
He has been prescribed. Um, I don't remember what the injection is. It starts with a D. It's similar to Lupron, not Lupron, with a second generation release, but similar.
Yeah. But are they giving him pills before that injection?
Yeah, the 30 days. Yeah.
They are bicalutamide.
Yes.
Okay, that's good because they don't always, sometimes they forget that.
No.
Okay, it's good. No, I'm really pleased to hear that. Now, how many metastases did he have in total that showed up on the PSMA scan?
I don't actually know. I just know the locations. From what he said, it sounded like one in each place, but honestly, I have my doubts. He wasn't shown the PSMA scan. This is why I will be going with him to the medical oncologist appointment because I will be asking to see everything.
Good girl. Good girl. Are you in the medical field?
Not even a little bit.
Okay. No, okay, I'm really impressed. No, it's great. The reason we ask is because the NCCN guidelines, which are not the Canadian guidelines, but they should be the guidelines by which Canadians treat, it would make a difference how many metastases he had as to his treatment. So it's really important. Does your dad have? Well, let me ask a couple of questions. I'm not really going in order that we usually go. Does your dad have any comorbidities? Does he have any other medical issues that we should be aware of?
He takes a statin. He
Okay.
has had a small stroke before. That's why,
Okay.
so he takes like an aspirin every day.
Okay.
And he recently got a procedure done for a stent in his abdomen because he had a small aneurysm. It wasn't at the size that normally they operate, but they were being proactive on it and he got it taken care of. Other than that, he's a pretty healthy, fairly active, goes for walks and eats fairly healthy,
Good.
not very overweight guy. Dad doesn't really have any issues otherwise.
Okay. So he doesn't pig out on strudel and schnitzel.
Well, depends on the day, but especially since the cancer diagnosis, he has cut out most of all his sugar. He definitely doesn't
Okay.
eat too much, but yeah, he
Okay. Just
yeah.
just 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 checking. Now you mentioned you're going to see a medical oncologist. Do you by chance know if that's a general medical oncologist or would this be somebody who specializes in prostate cancer?
Good question. I'm not sure because the appointment hasn't actually been booked yet. He was just told by the urologist, who's the one who told him his staging, that a medical oncologist will call him, or the office will call him to set up an appointment. I do know that there is a prostate cancer center in my city, so I can only assume that someone with stage 4 cancer would be treated at the prostate cancer center.
Yeah,
I
maybe.
guess we'll find out.
There's a dire shortage of well, let me step back one. The medical oncologists who specialize in prostate cancer are known as genitourinary medical oncologists, GU medical oncologists. There's a dire shortage in Canada. You could probably count them on two hands. So, especially given the way that the National Health Service works in Canada, and especially since it's province driven, probably it's going to be a generalist. And if it's a generalist, then you become really important because you have to be directing the generalist, and it depends how willing they are to listen to you. They should be, and sometimes we find they are, but it's not always the case.
Well, I'm loud, so I'm willing to fight someone.
Good. Okay. So let me see. Is there any cancer in your dad's family?
Yeah, his mom died of cancer, but she was a very, very, very heavy smoker, and she died of lung cancer. So,
Oh,
other than that, not to my knowledge.
okay. So let me give you a couple of things, and then we'll throw it open to the group. A couple of things that I think are really important for you to raise with the doctor. First of all, the standard of care for somebody diagnosed de novo metastatic, which is what your dad is, meaning he was metastatic at the time of his first diagnosis. That's what de novo is, that they get somatic testing. And somatic testing is to test the tumor to see what mutations are in the tumor. And the reason it's done is because there are certain precision medicines, personalized medicines that come into play depending on what comes back. So it's hard to get that in Canada, but you should be leaning on them to do it. If you wanted to do it independently, you can, and there is a Foundation Medicine has a Canadian site. And if I've got a moment, I can try and put it in for you in the chat window. But they definitely have a Canadian site, and they do subsidize the cost. So you can get the samples drawn in Canada, they're analyzed here, the results are sent back to you. You will have to pay privately, but you won't pay the full cost. I think they will pull it down to something less than $500. I heard this morning that the $2 were at parity. Is that right? You don't know. Okay. Well, anyway, because it's usually Canadian dollars worth less, but I heard it was at parity with this rubbish with our emperor. Now, so the first thing is somatic testing. Depending on the results of that somatic testing, you may need to see if any of the mutations are inherited. So that's important for you. If your dad inherited a mutation, he could have passed it on to you or any of your siblings. Do you have any brothers? Okay. So we probably should be doing, if he was in this country, he definitely would be getting this testing. And then we would go to the second step, which is the germline testing, but we would only do it based on the results of the first test because we may not need it.
The dollar went up in almost every country in the world today. It definitely went up against Canada. It's now 69 cents today for a Canadian dollar.
Thank you, Jeff. Thank you. Now we know. Okay. Now, the second thing is that for somebody with your dad's diagnosis in this country, if he's got five, to be safe, we'll say if he's got 5 or more sites, which it sounds like he's pretty close to 1, 2, 3, 4, 5, I can count 5. He would get what's called triplet therapy, which means chemotherapy upfront, chemotherapy, an androgen deprivation drug, which they're setting him up for now with a 30 days bicalutamide.
The first generation and the second generation.
Right. And he would get a second generation drug. You're absolutely right. You've been doing your reading.
I've been doing research for weeks. I probably know more than you think.
Okay. Now, what you may not have read is that given that he's got these arterial issues and a history of them, that second generation drug should not be enzalutamide. It probably should be abiraterone. That's what we would suggest as the first drug. He's not going to get darolutamide in Canada just yet. So we would say, and it probably gives the best results anyway, that he should be talking to his doc about an ADT drug like Eligard or Zoladex or Lupron, plus abiraterone and prednisone, plus chemotherapy. And that would give him the best results. Chemotherapy would be docetaxel. And we can support him when he goes through all of this. We've had guys who have done that. So having said all of that, I'm going to turn it over for the next 10 minutes for whoever wants to talk. Jeff Marchi has his hand up. So what's on your mind, Jeff?
Yeah, the Gleason score wasn't complete. She said 3 or 5. The Gleason score has 2 numbers, 3, like
Right.
3 plus 3, 5 plus 4.
She
4
did
plus...
say that. She said he had a bunch of 5 plus 3s, but we're not sure on the other 2. She said we have a bunch of 5 plus 3s.
So yeah, out of 14 biopsies, this is what we were told. And again, I don't think the way it was delivered was very clear. I'm not sure my dad fully has a full clear picture on what his Gleason score was. I think with the stress, he didn't fully take it all in. But what we were told was there was 14 biopsies, 10 of them came back as a Gleason 5, and then 4 of them came back as a Gleason 3.
Exactly what I was saying. It wasn't complete.
Didn't you say that there were 5 plus 3s? Didn't you say 5 plus 3s?
No. She said the same thing twice.
Jeff. Thank you. What? Tell me again.
To my understanding, and maybe you guys can explain Gleason scores to me because I don't know if I fully get it. But to my understanding, it's you take the 2 most common Gleason scores, add them together. So I would assume that would be a 5 plus 3, but I could be wrong in understanding what it means.
You are right, and that's why you said 5 plus 3. But let me explain how the Gleason scores work. They take the biopsy and they look for the most frequent pattern, the second most frequent pattern, and sometimes the third most frequent pattern. And when we talk about Gleason scores, we usually talk about one number that's made of 2 other numbers, the first most frequent pattern and the second most frequent pattern. So it could be that he had 5 plus 3s, 5 plus 4s, or 5 plus 5s. What I thought I heard you say is he had 5 plus 3s, but it's whether those are in the same biopsy. Now it will be, you need to get a copy of the biopsy report, and it will tell you in the biopsy report. But when we're talking with somebody who had 10 cores, which had at least a 5 in it, it's less important to me whether those were 5 plus 3s, 5 plus 4s, or 5 plus 5s. Because the bottom line is we're probably going to treat him the same way. And especially when he is medicine. In the long, in the, okay, whoever just came in, please mute.
Got
Thank
him, Rick.
you. In the long run, we will need to know it, but it's not relevant for where your dad is right now, in my view. I don't need to know whether he was an 8, a 9, or a 10. He was one of those, and he'll tell us, or you'll tell us next time. Dr. John.
Yeah, I was going to. You can email us the biopsy report, but as Rick says, he's definitely in grade group 4 or 5, and he's going to have aggressive treatment with 3 drugs, and regardless of the finer details. I was wondering also what his blood pressure was like.
Oh, wrong one. You turned your picture off instead of turning your mic on.
Oops. I don't know his exact numbers for his blood pressure. I do know it is on the higher side.
Okay.
Sometimes
And
that can
was
be
that stroke?
he gets white
Yeah.
coat syndrome. But yes, he also has had a stroke, so that says a lot.
And the stroke was it a bleed type of a stroke or an embolus type of a stroke?
I believe it was a bleed, and it was very minor. And he
Okay.
had very quick recovery.
Okay. Well, you do want to make sure his blood pressure gets well under control, especially if you get on this Abiraterone drug.
Is he taking blood pressure medicine right now?
Yeah, I believe that's what a statin is. Yes, he is on a blood pressure medication.
Okay, the statins for cholesterol, and that's
Oh,
also
well, I
good.
believe no, maybe it's just the aspirin.
Okay. Well,
I will ask.
Dr. John raises a really good point. Be sure to talk to the medical oncologist. If he puts him on abiraterone, be sure to talk to him about blood pressure, because if he's got high blood pressure, he's not a great candidate for abiraterone either. And he's not a great candidate for enzalutamide, because we know that there are issues with enzalutamide related to strokes. He is a good candidate for darolutamide, but I don't think you can get it. And he may be a candidate for apalutamide. If we can get his blood pressure reasonable, and if he could try the abiraterone, because that's really the best drug to start on. But it's all also along with the chemo, and as long as he's got at least 5 lesions, don't let them put you off by saying, no, you don't need it. You say to them, but that's not what the NCCN guidelines say. NCCN is the national, the National Cancer Center Network.
Comprehensive Cancer Center.
Sorry, National Comprehensive Cancer Center Network. I stand corrected. And again, we can send you those guidelines if you want to take them with you to the appointment.
Yes, I
Okay.
would. So can you reiterate what are the 3 drugs? So it's the chemo drug, and what is the
It's
second?
the first line. It's the first line ADT drug.
Yeah, which he's going to do Eligard, I think.
Eligard. It's a second line anti-androgen, which we would say, if he can tolerate it, abiraterone.
Okay.
But if he cannot tolerate it, then darolutamide, because it doesn't cross the brain barrier, and we're concerned about that. And then chemotherapy, which would be docetaxel.
Okay. Thank you.
Now, Dr. John or Dr. Jeff, do we need to be concerned about the prednisone if somebody has these type of comorbidities?
I'll take that. Not as long as the blood pressure is very carefully monitored and under very good control. Not just decent control, very good control.
Okay. Okay, so again, you heard that.
I did.
Agreed, Jeff?
Taking notes.
Okay, and
And
you'll be able to find this. Hold on, Dr. Jeff. You'll be able to find this. This is recorded. So give us a couple of days. You'll find it on our YouTube channel or otherwise. And send us the email that you'd like us to use for the interim. Could be yours, is fine. Okay, you can put it in the chat window and we can put him in under your email and then you can pass the stuff on to him. Or I mean, it's great that you are there as a faucet. Dr. Jeff?
yeah, I mean, taking prednisone has its risks with hypertension. So I have hypertension. I take prednisone, and you got to make sure your blood pressure is, as you heard, very, very accurately managed in the normal range.
Okay. All right. Anything else, or if not, we've a lot of people that need time tonight, so we'll just move on.
But I just want to make sure you through all of these terms and words.
You're really muffled, Larry Fish.
We
Or
through. Can you hear me better?
no,
All right, let it go. But
you're
I want to
very,
make.
very, very muffled.
All right, I'm gonna change my mic. I'll change.
Okay. All right. So just let us know. Let me know how to get hold of you so I can send you the NCCN guidelines so that you'll see. And when I send them to you, we'll point out exactly where it says that he should be getting triplet therapy.
Okay, thank you. I will.
Okay, and Dr. John's it's either Dr. John at AnCan.org with a period, Dr. John at AnCan.org, or I'm RD at AnCan.org, and one of us will take care of biz. Okay, and next week, this meeting is on Tuesday, and 2 hours earlier. So if you come into this meeting next week, you might find Greg Leshevsky talking to Dr. Mark about low intermediate, which you don't need to listen to. But this meeting is at 6 o'clock. We send out a reminder, and with your email, we will you'll get the reminder. Okay? All right. Thanks for coming in. And your dad has a great daughter, and we'll tell him that if we see him on this group. All right. I'm going to start going to people first, and I'm going to go to Commander Adam because I know he often drops off, and I want to be sure that we don't lose him this time. And then we'll go to the people that we missed last week. And anybody who came in after 10 minutes after the hour, if we have time, we can take your questions at the end, but we ask you to be here in the first 10 minutes. As you can see, it's a big group, so I can't we can't poll you right now, I'm afraid. Oh, look, we have Brian Haack and the other Haack. We've got the two Hacks. We got two Hacks in this group tonight. So how about that? Commander Adam, go ahead,
Yes.
please.
Yeah, thanks, Rick. I appreciate it. It's been a long time for an update. So a quick update and then a very quick question.
Yes.
So I was able to finally get in to see Dr. E for my second set of scans and everything, did a full body MRI, did another PSMA PET along with the blood, and got the results of the all the different types of genetic testing. Good news, everything is still progressing in the right way. She said I'm down to just 2 tumors after starting out with probably 30. One in the prostate, obviously, and then one in the hip, and they both show signs that they are both continuing to diminish. So that's all good. She did switch me from, I was on Eligard, and then I was on Erlita, and she switched me from the Eligard to Orgovix.
Right.
And I have noticed I didn't really feel like I had any significant side effects with the Degarelix, which I started off with, or the Eligard. The Orgovix had me kind of feeling funny, I think, in the beginning, um, but I got used to it. Whatever. The maybe a little bit more mental acuity issues. Um, so then she'd also recommended, because even though I'm very active and I do a lot of exercise most days of the weeks, and my diet is plant based, although putting in more animal protein these days. Um, I can't keep the weight off, and that's been more of a problem since switching to Orgovix. So she said, "Hey, why don't you take semaglutide injections?" So I actually did my first one a week ago, and I hate it. Just been nauseous the entire time. But my lead in with that is because, and I actually think it started just before the semaglutide injection, but I've been getting a rash on my neck, a very itchy rash that will come and go. First time I had it, it was there for maybe a day or two, then it left, and then it came back about 3 days afterwards, and it's been there since. And I'm wondering, is there any connection between Orgovix and a neck rash, or something that's itchy, or semaglutide and a rash? That's it.
Question. Are you, so she often puts people on semaglutide or something similar. General Joel isn't here tonight. You'd know if he was, because he usually has a picture of Dr. Eo looking over his shoulder. And I know that he did that for her. Are you taking a proton pump inhibitor? Do you use a proton pump inhibitor?
No.
Okay. Because we've seen a rash occur with Orgovix, but there is an interaction that we know of. Now, my docs are anxious to get at this one, so they may have some input. Dr. Jeff.
Yeah, my advice would be to get someone to look at it to make sure you're not having an outbreak of shingles.
Okay. What would be other symptoms if I were having an outbreak of shingles?
You could have pain, itching, a blistery rash, fluid-filled bumps,
No.
redness, or you should have somebody look at it. Is it on one side of your neck?
No, it's on both.
Both sides. Okay.
Yeah, it's on both, and no fluid-filled sacs or anything. It was just very itchy, and I haven't really, outside of being very tired lately. But then again, which of us aren't? I haven't had any other symptoms really.
Both sides very unlikely to be shingles. Not impossible, but unlikely.
Thank you.
I'd say a couple of things. The first is definitely let Dr. E know.
Okay.
If you haven't done so, please tell her. She's real good on this stuff, and she will know better than anybody how to make that adjustment, is my guess. Secondly, we have seen people on Orgovix have rashes, but I know in one case or two cases it was because they were taking a proton pump inhibitor, but I don't remember if it was in every case.
Okay.
But we've seen it where they've come up with a rash when they didn't have a rash when they were on either a agonist or even an antagonist. Dr. Jack.
Yeah, I take Orgovix now almost 2 years, and I've had a lot of itching and very small rashes. And I spoke to my medical oncologist, and he said very, very characteristic of dry skin associated with no testosterone. And he sees it all the time. He told me your skin's very dry, try and put moisture on it. See if that makes a difference, moisturizing it as much as you can.
Okay, thanks.
Dr. John, see, all the doctors are waiting in for you, Commander. See that?
I was wondering what dose of semaglutide you got started at.
Ooh, that's a good question. My wife would know.
Well,
Uh,
let me put it this way: you had nausea, which to me is clearly from the semaglutide. If you got started on anything higher than 2 milligrams, then switch to 2 milligrams until all your nausea goes away.
okay. All right. Yeah. I think, yeah. Okay. So 2 milligrams until the nausea goes away. Got it. Okay. We'll do. Thank you.
Okay, we don't give medical advice in this group unless you're a doctor. Okay.
I appreciate it.
Anybody else? Now, semaglutide is one of those drugs for appetite, isn't it? For slimming, or am I
Yes,
wrong?
yes, you're
Right.
right. Ozempic.
Yes. So, and yeah, she used it, and she used it in another case that I'm very familiar with another of her patients who's an AnCaner, but not prostate cancer, and it's worked great for him. It's worked really great for him. So, bear with it, or maybe you need to switch that drug, and she'll know that.
Yeah.
Gents, do we know if there's any interaction between semaglutide and Orgovix? There's one for you to look at.
I'll check.
Jim, Captain Jim.
Commander, do you possibly snack at night?
No,
In the
I
case
would
of the
say
munchies and, a bag of Fritos or something like that?
no, definitely
No.
not on my diet, and
Okay.
especially since I will tell you the semaglutide does work. I mean, I just do not. It makes me nauseous to even think about food. It's very weird. Um, but yeah, I don't eat with the semaglutide. I've barely been eating anything.
Okay.
So how much are you gaining? In other words, is it a pound here, a pound there, or 5 pounds or 8 pounds or
it,
what?
it, I kept going up. So, and I'm not obese. Like I said, I'm very active, but my my normal weight's about 170, and throughout the initial, parts of the diagnosis and everything, I was 170 or lower. But since I've really been able to get on, the early in the Eligard and stuff, I'm at 190. I mean, 190 to 195, 198. And yeah, I mean, and that's just way too heavy. And like I said, again, I'm very active. I work out at least 30 minutes a day, doing running, jogging, rowing, biking, weights,
Okay.
um,
So
everything.
How
let me
tall
just
are
say,
you?
what was that? Did
I'm
you say
sorry. I'm sorry. That was me. I didn't mean to burst in. I was wondering how tall he was.
5'6".
5'6"? Okay.
You
So
probably have a BMI
we
over
get, we're
30.
we're going to have to move on, Dr. John. I'm sorry, but I'm just watching the time. I'm sorry I can't take the hands that are up right now, but I've really got to trying to be aware of the time. And Michelle, I put the Canada link for you for Foundation Medicine in there. And just one thing you should know, um, I, I put on 15. No, I put on. Yeah, I put on over 15, 16 pounds when I was on those ADT drugs. But I think a lot of it was water weight, and that's also something that you might want to talk to Dr. E about, because it could be that a lot of this is you're just carrying a lot more fluid,
Sure.
and discuss that. All right, I'm gonna keep moving through. Make a note of what you wanted to say. If we've got time, we'll come to you. But otherwise, I've got to keep pushing along. Um, Jim Thompson, we deferred you from last week.
Yeah. Good evening, everybody.
Good
I
evening.
I went and had my second shot last Wednesday, and I found out that I was stage 4, and my PSA at that time was 50. My PSA was 56, but I had some blood work done also last Wednesday, and I have not gotten the results from that yet. So I'm waiting to get the results from that to see what my PSA is now. And
Okay.
also, I have a question. I
Well,
talked to.
before you get to your question, let me just. I just want to look at something. I mean, I think we knew you were stage 4, and we discussed that last time. And was this your first? This was your first shot, is that right, Jim?
My second shot.
Okay, so
Yeah.
are you telling me that your PSA was 56, even though you'd had a shot?
No, my PSA was 56 back in October.
Yeah.
And my blood work done when I had my blood work done Wednesday. I have not gotten my results back yet.
Oh, okay. So, I mean, we did know that you were metastatic. Um, you had um, prostate cancer in your lymph nodes,
Mm-hmm.
and so we were well aware of that beforehand. Um, and so what we hoped that we would see was that it had gone down. So we're anxious to find out where you are right now. Now, are you? It was the VA that you went to this time, correct?
Yes. Mm-hmm.
And where do we stand in getting you to Dr. Pala?
I did ask for a referral, and I asked the oncologist at the VA, did he know Pella? And he claimed he didn't know her, you know. And I said, well, can I get a referral? And he said you don't really need a referral because whatever they do, I can do, you know. I said, well, I still would like to get a referral, to get a second opinion. And he just act like, I don't know, he just acting, too nonchalant for me.
Oh.
Dr. Kresno, you know him at the VA, Doctor. I think it's Dr. Kresno.
Well, here's what I would say to Dr. Kresno. You're a general medical oncologist. He's a medical oncologist, right? He's not a urologist.
No. Yeah.
Yeah.
I would say, Dr. Kresno, you're not a genitourinary, and I know I need a genitourinary, and I'd like a community referral, please.
Right. Okay.
And Captain Jim, this is in your backyard.
It's in my backyard, and in fact, I did the same thing. I told him that. He said, "Oh no, I can handle it." And so I walked out of there disappointed, but he refuses to refer us over. So I have to go to Plan B.
And what's Plan B?
Try to use TRICARE for life, but that has some hurdles because of the Kaiser. But I believe I know how to get around that. So I am currently working on it.
Also, I went to Kaiser, and my doctor at Kaiser too also told me that he can get me a referral because he know her. He know Dr. Paula, and he said that he can get me a referral once I let him know my Gleason score and my stage and all that, which I couldn't even get my Gleason score Wednesday. He told me I didn't. He said it was, as long as it was out of your prostate, you don't need a Gleason score. That's what
Okay,
he was.
well, there is a reason for that. And if you've never had a biopsy, then he's sort of right. We don't know your Gleason score. And your doctor at the VA and your doctor at Kaiser, you have to say to him that you were de novo metastatic and you've never had a biopsy. If he insists on doing a biopsy, which he could do, just do it at Kaiser and let him get you the referral to Channing Pala.
Hey, well, I have a biopsy report from the VA. I had that.
Oh, you had a biopsy?
I had two. Yeah, I had two biopsies.
Well, you need to tell Kresno. You need to tell Kresno to take a hike. You want to know. You're entitled to know your Gleason score, and you want to know what it is.
Hey, he definitely would not tell me. He told me I didn't need it. That's what he said.
Well, you tell him you need to know. It's not up to him. You have to tell. These doctors that act like God. The only way we're going to stop them acting like God is to stand up to them. And you're entitled to a copy of that Gleason, of that biopsy report. In fact, I would go into the VA. I would go into your VA portal immediately after this and request in writing for your biopsy report.
Well, I'm going tomorrow, and I'm going to the urology and try to get my report because the urology, she did it, and but she didn't explain to me about the Gleason score. That was back in October. So I'm going tomorrow, and I'm gonna sit and talk to her and get her to explain everything to me and get my Gleason score.
And then the other thing is, and we won't get into this, and this is something to discuss in the veterans meeting tomorrow night.
Right.
We have to figure out how to get around this guy Cresno or to report him.
Oh, okay.
Okay.
Right. Okay.
Because when senior people come down and he's giving patients this rubbish. You don't need your Gleason score. You don't need this. You don't need that. He needs taking down a peg or two, Captain Jim. And I don't know how you do it at the VA. I can tell you that if we mention this to Mike Crosby, he'll figure out a way to do it.
Yeah. I plan to.
Okay, so we have to let Mike Crosby know that there's doctors. There are doctors who refuse to refer to community care when they're not GU medoncs. Number one. Number two, they won't even inform their patients. And Mike has the means and the way to deal with that. But to me, it's just outrageous.
Yeah. Yeah. Rick, at this time, that's all I have at this time.
Okay. Anybody else have anything for Jim?
What's Cresno's first name, please?
Oh Lord.
I think it's Stephen, but I'm not 100% sure.
It is. It's Stephen Cresno.
Dr. John, do you have any advice from all your years of experience how to deal with a doctor like that in the VA? All of your years of VA experience?
Well, I used to just go down to their office and sit in on their patient visit and influence it myself. Now, you won't get too many primary care docs doing that for you, So you'll probably have to do the communication with him yourself.
Okay.
Okay. And are there lines in the VA? Are there lines of for complaints where you feel
Yes,
if you feel
yes. There's something called the patient advocate, and the patient advocate will handle your complaints with you.
Okay.
At least in primary care, there's a patient advocate. I don't know if they go to the specialties as well. Anybody know that? Okay. Start with a patient advocate in the primary care and work from there.
Yeah, and let them know that the medical oncologist will not consider an outside referral, even though he's not a specialist, and that he's also refusing to provide you with information.
Right, I will do that tomorrow when I go up there. I'm going up there tomorrow, and I'll definitely do that tomorrow.
Okay, and thank you, Dr. John, for the benefit of your experience. Really appreciate it.
I say thank you also. Thank you.
Okay, we're gonna keep rolling, and the next person who got deferred from last week is Gary N. and then Thomas. So Gary N., what was on your mind last week?
Well, let me give you a quick update, and then I'll get to my question. I had PSA and testosterone levels measured January 27. The PSA was 2.25 CMIA, but that's down from 162.65 in late November and over 1,000 in late October. So I know they want to get it lower than even 2.25. So I will get it. It will get measured again at the conclusion of my chemotherapy in early March. Testosterone was 13 on January 27, down from 380 in late November. I got my second Eligard shot today, and I've been on darolutamide, Nubeqa, and docetaxel. I've had 4 infusions. I think I'm tolerating the triplet therapy pretty well. No nausea or vomiting, thank God. Probably the biggest problem I've had to date is inability to get a decent night's sleep. Probably 3 out of 4 nights I've got restless leg syndrome going, and frequent urination over the course of the night, 4 to 5 times. So I'm not even getting, at best, probably 2 hours of sleep between visits to the bathroom. And what I'm wondering is, does that sound like the result of the meds, the restless leg, and frequent urination? Is there anything to do to mitigate it? That I should also mention, in addition to the cancer medications, I take 80 milligrams of Cymbalta a day. I've been taking that for years for depression, and I had also been on. I'm still on trazodone, which is supposed to help me get to sleep, but I swear, even though I can't find anything online, I swear it's a diuretic. Because nights I don't take the trazodone, I'm not up 4 or 5 times. I may be up 2 or 3, but I can't find anything at all that indicates trazodone is a diuretic. Anyhow, any thoughts other than just toughing it out?
Well, I'm sure I know Dr. John wants to weigh in already, and there may be other issues. One question I have is, are you feeling depressed still? Because that can happen as a result of going on the ADT. Do you feel that the Cymbalta needs to be the dose of Cymbalta needs to be adjusted at all?
It actually was just adjusted. I know the Shar Center has a psychiatrist on their staff who just deals with cancer patients, and he had bumped me from 60 milligrams to 80. On the trazodone, he had bumped me from 75 to 100, but we've stepped it back to 75 because it was making me unsteady on my feet.
Okay. Well, let's get some input for you, and then we'll see where we go. Okay. If everybody can try and keep their comments pretty short as well, that would help with so many people. Let me start with Dr. John.
Okay, hi. If the trazodone if you've tried off and on and off and on, and the trazodone is clearly associated with frequency of urination, then, no problem. Just switch to another something else to help you sleep, and maybe it won't have the same effect. If, in fact, you do have restless leg syndrome, which has specific criteria, you can't really just make a casual diagnosis of it. There are a number of medicines that you should try first before just trying to suppress it. Specific medications that are good for restless leg syndrome, but make sure that you meet the criteria for the diagnosis. And the last thing I wanted to know is whether you've looked into the idea of being on a bone strengthener.
Yes. Thank you, John.
The GI oncologist, GU oncologist, has indicated he wants me to start that as soon as the chemo is over.
Okay.
For now, I'm just taking a calcium supplement.
Okay.
John, is one of the drugs you had in mind gabapentin? Because it was as an alternative to trazodone.
Gabapentin might be a possibility. I mean, I was thinking of something like the drugs that are used for Parkinson's disease, or kind of good for restless leg syndrome, or even a simple clonazepam, benzodiazepine type drug would be good for that.
Mhm. So let's keep moving around, and I'm really glad to hear that you're. I'm really glad to hear that the doc's going to put you on a bone strengthener when you're done. The other thing to discuss with him is whether you're a candidate for one of the drugs that relaxes your bladder, and there are a number of drugs that fit that bill. Did you have these bladder? You didn't have these bladder issues before, is that right?
Not to this extent.
Okay.
No.
Well, there were a number of drugs like Mobigron and others that are pretty good. There's a host of drugs, but I think you should be reaching out to your med-onc, to Dr. Allen, and saying to him, look, can you give me something?
We did discuss it, Rick, last visit, and he said, look, there are drugs, because I said, I feel like my bladder is emptying. He said, well, you may feel that way, but it may not be. He said, there are drugs that will assist in emptying the bladder, but I don't want to layer another drug on top of all the stuff you're taking unless it's really necessary. So the issues out there with him, I was
Okay.
hoping.
This is not so much a drug for emptying the bladder. There are drugs that relax the bladder so they don't spasm so much. And so you don't feel it, so it doesn't wake you up. But let me go to the other, and I know that Matt mentioned he has restless leg. Matt, do you associate that with any of your treatment issues?
I haven't been able to pin it down, so I'm currently kind of trying to see if there's a direct association with any of the medications. It does run in my family, but I've never experienced it until I've started all these treatments, so I'm just trying to figure it out now.
Okay. Now, what's the drug we talk about in here that is a spray that you can spray on your legs that helps with restless leg? Anybody know? Dennis Correa. Is it a zinc, something with a zinc base? Or something?
Magnesium?
Maybe it's
Capsaicin?
magnesium. I don't know, but there's a drug that we talk about in here quite often, and you can either spray it or it comes on as a cream, and it helps with cramp. I'm thinking maybe of cramps rather than I'm thinking of cramps maybe rather than restless leg, but leg cramps. All right, Mark Valens, sorry.
No, I got restless leg when I was on Zytiga, and for me, pramipexole took care of it. Just I take a pill once a day, pramipexole. So you might want to try that. It worked for me.
Could you put that in the chat window, please, Mark?
Okay.
I can do it because I know how to spell it.
Okay, thank you, Dr. John. Okay, hold on a minute, and then Dr. Jeff.
So lack of sleep can actually precipitate deterioration of restless leg syndrome. So if you're not sleeping well, that could be contributing to why the restless leg is persisting. And one of the things you could look for, and I know there are guys on here who have had it based on our conversations, is to get tested for iron deficiency. And I'm not saying anemia, iron deficiency. You can have low iron and not be anemic. So they have to order your serum iron, your total iron binding capacity, etc. But low iron can cause restless leg.
How are you doing?
Okay.
My wife had it, and iron helped her a lot.
Okay.
Okay.
So get tested. Great suggestion, Dr. Jeff. Jeff Marchi, very quickly, please.
Yeah, a couple things for urgency and incontinence. If you're having the urgency multiple times at night, I had it. My doctor put me on Myrbetwick, Myrbetrik. There's
Yeah,
also
that's the
another
same.
drug,
That's the same
Gemtesa.
as Merbigron. That's the
Yeah,
same as
yes,
Merbigron.
exactly the same. And Gemtesa is another one, Gemtesa. Those both help with urgency. I used to wake up a bunch of times at night and feel like I had to go, and it just totally stopped it and really helped with incontinence too.
Thank you, thank you, Jeff. All right. Anyone else? Or we're going to move on? Got to be quick today because we've got a lot of people. Thomas.
Yeah, hello, thank you. I don't have a medical need right now, just an informational question about Dr. John's write-up regarding fractionation in radiation treatments. And I read the note in the invitation, and my question is, does any of that discussion have any relationship to palliative radiation for bone pain, rather than a treatment as discussed in Dr. John's write-up?
Palliative treatment for bone pain tends anyway to be hypofractionated. It's usually SBRT, CyberKnife or something like that, and is usually only a few sessions precisely aimed.
Okay, sounds like a pretty direct answer. That's all I need for tonight.
Okay, Thomas. Thank you.
Thank you.
Thanks, Thomas. All right. Now let's get to who needs time today. A couple of people that I know have been having treatment issues, so I want to sort of get to them first, and we'll start with Mark Valens.
Well, I was having some major problems last week. I had a FDG and a CAT scan that both said I was doing just fine, that the cancer wasn't spreading or anything else. And then 6 days ago, I had a PSMA and it came back. I had bone metastasis and other metastases all over my body. It was quite a surprise because I was feeling really well. But it had basically, my medical oncologist said the chemo failed. The chemo was not stopping it from spreading, and it spread a lot. But anyways, I just an hour and a half ago had a good talk with Dr. Agarwal at UCSF, and he's not as worried as I was. He's putting me on Pluvicto, and he was able to determine that I do not have any neuroendocrine issues. There was a question whether I might, and he was able to see that my FDG and my PSMA is concordant, which is good. That means that there's not a neuroendocrine, which I was worried about. Let's see I do have a whole bunch of new lesions, but he's not so worried about that. He said I've got at least another year, and so we're just going to take the Pluvicto and see how it goes, and left me feeling hopeful, which I was not feeling last week. So there I am for now.
So this is what you and I discussed on Friday, and we hoped for that he'd put you onto Pluvicto, and I just have a gut feeling you'll do quite well on Pluvicto. I think it'll bring everything down, but that's just a hunch. And was he was in agreement that you should quit the docetaxel?
Yes, and he said we can go back and use it again.
Yeah.
Because maybe it's doing something that Pluvicto won't do, but we're aiming for 6 sessions, 6 weeks apart of Pluvicto. But he said after 3 cycles, we might take a break.
Yes. Okay. I mean, I'm going to put it in my notes as 3x times 2 because that's exactly right. I mean, what we see is that if men don't respond or they don't do that well, probably not a bad idea. At the same time, we've had a bunch of guys who didn't respond till the third or fourth session, and then they responded. So, if you might not see any movement for the first 2 sessions, if you see something good on the third, then it's probably worth doing a fourth. But there's a lot of flexibility, and so I'm pleased that that's what he's thinking, and and I'm looking beyond 12 months. Just saying. Now, anybody would like to comment for Mark? Oh, we got a hand up. Whose hand do we have up?
I'm sorry, Rick. It's me again, and I'm
Oh,
sorry for butting in on all these things, but you keep on
no, perfect.
raising questions that I've got ideas about. But Mark, my idea is that because you're not highly symptomatic and because there's nothing urgent about it for someone that's failed docetaxel, I think it's fine that you not move right to cabazitaxel. And I think Pluvicto is a good idea, particularly considering you're very much PSMA avid. The only caveat I would put in is if you happen to be BRCA positive, and last time I talked to you, you had somatic test pending, then you might be better off going to a PARP inhibitor than Pluvicto.
No BRCA issues.
And that's from the somatic test that you had,
Yes.
the self exam. Okay, very good. Thank you.
Thank you.
Just remind me again, because I'm not sure I wrote it down, or I have your report, but there was no BRCA, but there was one gene that showed up, correct?
P10.
Yeah, P10.
And Dr. Agwal wasn't worried about that.
Right.
He said that's just common.
Right. We would expect to see P10. We would expect to see one or two of those guys, TP53, P10, or RB1. So, yes, Frank Jambra.
Oops. Hi. Yeah, I just finished my fourth round of Pluvicto last Tuesday, and I feel great, man. I was in this pool today swimming for 2 hours. I did water aerobics.
Good for you.
And that's only a week after of my treatment. I rebounded so well. But anyway, I just wanted to encourage you that the Pluvicto is working for me, and I'm living my life, So yeah, I wanted to
Fantastic.
encourage that.
Any tips for Mark?
Oh, yes, hydration is the main thing. And it's hard to hydrate when you're sick because, my reactions to the Pluvicto, and now I'm not saying these are going to be your reactions, but my reactions were like my stomach was like not vomiting, but retching. What else was it, honey? Yeah, constipation, no appetite. Well, it is. So I combated it. Like 3 days before, I started guzzling water. I started taking stool softeners. But I had learned this. This was just the fourth round. So the first 3 rounds, I kind of like figured my way through it. So yeah, you better start. I number my bottles of water. Like right now, I'm on 4 today, and I still got to put 2 more down. It's 9:30, so. And I went, so anyway, you got to hydrate because you got to get the Pluvicto out of your system because it'll ruin your kidneys and your liver and stuff. Is that right? Kidneys. So yeah, you got to get it out of here. And it's got to come out one way or the other. So I'd rather, got to pee it out and poop it out and instead of vomiting it out. So anyway, you're good. Thank you.
Thank you, Frank. Okay, we're going to keep moving along. There's some good advice for you, Mr. B. So, and when are you starting and where are you going to do it?
Should be able to do it right here in Medford. I haven't talked to Dr. Sandu yet. Hopefully before the end of the week or next week.
Okay, great. Okay. Okay. We are going to go to Matt, and then after Matt, we're going to go to Michael Chandler. So, and then I'll tell you who's coming up after that. So, Matt, what's going on in your world? Any new animals in the zoo? That's the most important thing. Anything new? Anything interesting happening in the zoo?
Yeah. I mean, there's always something interesting happening. We have some pregnant animals that I can't talk about publicly yet, and we've got a couple new cat species coming in. They'll be coming in on a plane on Wednesday. So if this meeting was Wednesday, I could tell you about it, but I can't yet.
Okay. All right. Well, we want to scoop it, so you better let us know so we can put it in. We'd like pictures of you and the new cat so we can put it in the reminder, Mr. M.
All right, I'll send something out.
Thank you very
Yeah,
much.
I haven't been in a meeting in a while. Hi, everybody. I guess just kind of a catch up on my doctor stuff, but I realized I had some questions when once you got I forgot who it was talking about restless legs and urination stuff at night. I still have that stuff going on, but not for this particular cancer group, but my melanoma is still in radiographic remission, which is wonderful news. And I'm on about 9 months of my ADT and a few months out of my radiation therapy. But one thing that happened, I'm here in Sacramento with the Kaiser. My good medical oncologist, who was much loved, kind of a young phenom, he left Kaiser, unfortunately. But I pieced together a small team, same doctor as Jeff has there in San Francisco. So Dr. Harstark is handling my prostate cancer stuff remotely, which is wonderful. And I have a separate doctor for my melanoma up in Roseville, and I switched urologists because I hated my urologist. I have a young lady who I've only met once on the phone, but just interacting with her was literally 1,000 times better than my other one, Dr. Lindsay Yu. So things are really stable for me right now. PSA is undetectable. I'm just getting through the hormone therapy, and just new doctors, new year, kind of new me. And I'm on the Flomax, and she started me on Cialis every day. She thought that might help with urinary issues as well.
Mm-hmm.
Mine kind of vary. They're like, 3 times a night, 5 times a night. It depends. But the restless legs, man, I had no idea. I kind of forgot all about it till somebody in this group started talking about it. It was like a nightmare last night. Kept me up, but it doesn't happen every night. So overall, I'm doing really well, and that's kind of where I'm at. I don't really have any specific questions today.
Who's this new urologist you like, in case we have anybody coming in your area that we can refer,
Her name's Lindsay Yu, Y-U-H.
Okay.
And she's in Roseville at the medical center up there.
Okay. Great. I wasn't sure. You mentioned that. I wasn't sure if that was the old one or the new one. And be sure to tell Dr. Hartstark I said hello. Does she know you're an AnCanner?
Yeah, definitely. My first, you helped me get that referral from her in the beginning, and I let her know, and then she was gracious enough to take my case with no questions asked. She did say if I need any treatments, I have to go to San Francisco, and I told her no problem. I'm happy to go. Hopefully, I won't need them, but
2 years ago, I think it was at the GU ASCO, I asked somebody for directions because I didn't realize it was Moscone West. And after she'd given them to me, I realized it was Dr. Hartstark. And I didn't even say hello to her. I said, wait a minute, I know who that person is. So, but it was out of context.
Didn't you have gene testing pending? Am I remembering that right?
My gene testing was all complete. Everything was good. So Dr. Harstark did order it for me, and it all came back A-OK.
Okay. No,
Yeah,
no, no
she
unusual
ordered all the
news.
stuff. My first guy wasn't, so I had bone density tests. I'm on calcium supplements. I have osteopenia. Yeah, and I'm doing all the stuff that everybody preaches. I've changed my entire life. I'm eating well. I'm exercising. I don't drink. I don't eat extra sugar. So on and so forth.
Okay, is that good for Tina too? Has she changed all of hers, or is she having to? Is she happy with your dietary stuff?
Yeah, so, I mean, she's been trying to get me to live healthy for 16 years. So no, it took an outside force.
Okay, okay,
I
all
did, I
right.
did, I did. Oh, he might have answered it. I did ask Dr. John a question in the chat, but he may have already answered. Oh no, he didn't answer. Were those three drugs you put there? Are those three drugs that treat restless legs, and then one possible cause? Is that what the three things are?
The three drugs were drugs that I've used for restless leg syndrome,
Okay.
and the iron suggestion was Jeff's suggestion to make sure that your iron levels were normal.
Yeah, I think one of my last two blood tests, they're not testing my iron, but they're testing something, and it's just barely a little low, and one of the possible causes was low iron. So I'll have the doctor look at that for sure.
Okay.
Yeah,
Thanks,
yeah,
guys.
yeah. And again, also you could bring that up with Dr. Hartstock
Yeah.
because it's probably and she'll be right on that as well. So, okay. Anybody else questions for Matt before we move on? Okay, we're gonna go to Michael Chandler, who's also had recent treatment developments. Where are you, Michael? Still with us?
Yes, I'm here.
I
Aloha
see.
from
Aloha.
Maui. I'm have my iPad on, ready to take a video telehealth call from my medical oncologist, Raina McKay at
Oh, we like her.
UCSD. I was there for 6 days of testing, and my prostate cancer's back, and they found a spot on my spine at T10, and I'm about probably tonight after the video chat about to go on HRT, which I'm not excited about. And so if I click you gentlemen off, it's not because I don't like you, it's because I got to take the call. But thank you, Rick Davis, and thank you, AnCan, for directing me toward a learning hospital or center of health, UCSD. And I enjoyed a prostate summit on Saturday, a seminar conducted by UCSD for 8 hours. Um, and so I was going to talk about starting HRT, and I'm meeting with a telehealth appointment Wednesday with Dr. Brent Rose about my radiation on this spot on my spine, and hopefully the two docs have talked and they haven't found anything so maybe no radiation on my pelvic floor. And I also just wanted to tell all you gentlemen to make sure you always give a kudos to your caregivers. My wife's nearby, and we can't thank them enough, and we get lost and trying to beat this prostate cancer. So kudos to our caregivers.
Yes, definitely. And Cheryl is exceptional. Exceptional.
And so I can chime in a future AnCan video chat. I'm fine.
So I think that you're talking about Orgovix and Abiraterone and the spot radiation on T10. Is that right?
Correct.
Right. And have they ruled out that that was not from your former career as a race car driver?
Yes. Yeah, I spine damaged and up in my spine, have spine damage from old trauma and injury. And yeah, I abused myself when I was younger. And so the spot on my spine, the hot spot, is at T10, and it's all going to work out because I have the best team at UCSD.
Yes. Well, Rana Mackay is really good. I don't really know her. I'm really hoping I bump into her. I'd love to actually get a meeting, 10-minute meeting with her. You can ask her if she's open to a 10-minute meeting with us in next week in San Francisco, because I would make time. I'd love to see her on the Friday. Make sure you say on the Friday, because Friday's bladder cancer, and Thursday is, especially if it's in the morning, then I can pull Dr. John along, because he would love to. We'd love to spend 10 or 15 minutes with her. She's super special. I've known her for a long time of her, and I've referred loads of patients to her, but I've never actually shook her hand. So we'd love to
I
see her.
will.
And I think you are in good care. And it was one of the reasons why we liked UCSD in the first place, because we knew they had really good GU med on.
Well, good stuff. And thank you. And please go on.
Okay.
I'm good.
Okay. Anybody else have anything to say, for any thoughts, advice on this recurrence with a T10 metastasis for Michael before we move on?
Let me add 2 cents. 3 years ago, I had a radical prostatectomy. PSA was super low. In the last 6-8 months, it's been doubling. So it's back.
Okay. But we're on it, and we're gonna take it. We're on it, and we're gonna take care of it. Okay. Next person we're going to is Dr. Jeff.
Thank you. So I have two quick questions. Question number one is to anybody here who's taking Orgovix. I spoke to one specialty. They delivered my Orgovix. I'm switching from Lupron for the last 5 months to Orgovix. One specialty pharmacist said you have to take a loading dose of 3 pills on the first day, and then you take 1 pill forever. Another specialty pharmacist said, you don't need to take a loading dose, just start with 1 pill every day. So I'm somewhat confused. Obviously, these are opposite opinions. And I'm wondering, if you use Orgovix from the get-go, I would assume that's where you take the 3 loading dose pills. Is it different if you're switching from Lupron or Firmagon or Eligard to Orgovix, that you then don't have to take the loading dose? I'm confused by the necessity.
Anybody? I mean, rationally, I'd absolutely agree with you that you might not need a loading dose when you're switching across. Brian Haack.
Well, it makes sense, Jeff, what you're saying.
So
hold on, Jack.
Okay.
Brian Haack.
Was the Lupron shot, as that's what you're on, was that working and they switched you, or was the Lupron not?
No, it was working. It was working. Yeah. It was just, I had a terrible reaction to the last injection. I mean, I was really, really sick, high fever. So we're going to switch, and pain. We're going to switch, but it's working.
Probably then no loading dose would be my thoughts, but I didn't sleep at a Holiday Inn Express last night, so take it for what it's worth.
Okay. Dr. Jack.
Yeah, when I started Orgovix, I already had been on darolutamide for several months, and my PSA was so low. So I thought it would be best if I just do 1 rather than the loading dose of 3. And I've heard people who say 3, but 3 is usually when you're starting from scratch.
Okay, that's good. Yeah. Thank you. Second quick question.
Anybody? Hold on a minute. Hold on. Jeff Marchi.
I switched from Lupron to Orgovix about a year ago, and a year and a half, and I was never told to take a loading dose, just 1 pill.
Thank you. Anyone else before we get to Dr. Jeff's second question? Go ahead, Dr. Jeff.
Has anybody here experienced a reappearance let's say 18 months after radiation therapy of colitis, of radiation colitis?
Yeah, I mean, I've had, I don't want to call it colitis. I would rather call it proctitis. I don't know where, I don't know exactly where it's coming from, in what part of the passage it's coming from, but I've certainly had issues as a result of the radiation after 18 months. And I probably had sensitivity going in. Oh, one thing I did want to say on the last, when you start the Orgovix, make sure you don't get a rash on your neck.
I'll pay attention.
Okay, be paying attention for a rash on your neck, just in case. All right. But yes, I've certainly had gut issues arising from the RT, which probably started about 12 months afterwards, 15 months afterwards. Anyone else?
I can talk about the colitis. I finished my radiation last year. I'm on the holiday right now, and my ulcerative colitis seemed to be very well under control. And now that I've finished with the radiation some time ago, I've been having a much more serious time with colitis, and having to bowel movements, so frequent bowel movements every 4 or 5 times a day. And it started me to think that was it possible that the radiation may have affected the colitis. So right now, at this time, I'm not sure what the story is, or whether the colitis has now gotten a little bit more serious. So I'm not sure.
Anybody else want to comment on that? So, I mean, I know I've lived with radiation gut issues for the last 17 years, and I had a problem to begin with. They've gotten worse for me, especially in the last in the last couple of years, and especially in the last few months. But I don't even think about it. I figure it is what it is, and I deal with it. So, 4 or 5 bowel movements a day, that's how I am right now. But I just put it down to irritable bowel syndrome originally, and age, and a lot of radiation. And it's manageable. I just have to be aware. But I'll take it because I can do what I'm doing, and that gives me great pleasure. So versus the alternative,
I'm on Humira for the rheumatoid arthritis, which also is for ulcerative colitis. And I see these commercials about Rencro. Is that how they pronounce it? Rencro, which is made by the same manufacturer as Humira. And they seem to tout that this is a better treatment for colitis. Anyway, I'm going to bring that up the next time I see my doctor.
I think it's a good idea because I don't think we're going to solve it, and we've still got loads of people to get through, so we got to move on. Steve L.
Yes, thank you. Hey, I've been on Lupron and Abiraterone for almost 3 years now, so it's probably time I start worrying about changing the Abiraterone to something else. Is there also a recommendation to change the second generation drug? And any recommendations on which drug I should want to go to from Lupron?
there's a few things. The Abiraterone is the second generation drug.
Yes. Yeah. Do I need to change that?
Right. Probably the best thing you can be doing if you're in the right place if you're in the right position to do it, is to talk to your doc about taking a drug holiday. I mean, that would be the first place to go. That's what I would say.
Oh, even with a PSA approaching 1?
Well, then you're not in the right place to do it right now.
Correct. Okay.
Now, what we've got to figure out is, why is that PSA approaching 1? One of the reasons could well be that they've never addressed the primary. And so maybe, the first thing we do is address the primary and see if we can do that. Since we can't see anything else,
yes, and that is being addressed.
Okay, so I would say that yes, after 3 years on Lupron and Abiraterone, you probably would need to switch it up if your PSA was undetectable. With your PSA being detectable, it's not a good time to consider it. I wouldn't consider it, and but if it gets down to that undetectable, then yes, we should be considering things. Who else would like to comment on that? Jeff Marchi.
Yep. I switched from Abiraterone when I was having Abiraterone was 0.7 when when about the time my doc. Well, then I tried only dropping back to 3 pills, and it went up to 1. But going to darolutamide, I've been 14 months in a row undetectable. I was never 1 month I was undetectable on Abiraterone. And darolutamide, you have the neuroendocrine thing that you could worry about. It's easier to go from Abiraterone to darolutamide and have it work if you have not already failed Abiraterone. This is something that was discussed a few weeks ago. There's a very low chance if you failed Abiraterone that darolutamide is going to work, or one of the lutamides. But it sure worked for me, so that's something to think about.
When your PSA was around, you said your PSA was about 0.7, is that right, Jeff? Mark?
Yeah, that was about the.
And did they know where that PSA was coming from?
No, it was just going up and down. Remember, Rick? I mean, it went from 2 to 3 to 4 to 7, and it came back a little, and it was just totally unreliable. It might have been I was on Prilosec, and the protein pump inhibitor might have been a detract causing the problems with Abiraterone, never working 100%. But darolutamide doesn't have that conflict, so.
Yeah, I mean, it could have done. I guess it's actually Abiraterone, Jeff. I guess, Steve, that if the Abiraterone is working, or it's sort of keeping you relatively stable, and you know that they're going to do the radiation, I probably wouldn't change it until after the radiation, and then let's see after the radiation what happens. That would be my guess.
Understood.
Yeah,
how about on the Lupron? Do you think I should worry about changing that now?
Well, I don't know that switching that. I think what might make a difference is to go to Abiraterone monotherapy. Drop the Lupron altogether. That's worth discussing, because that's going to put the cancer in a different situation versus moving from Lupron to Orgovyx, for example, unless you've got an issue like Dr. Jeff had. So you might want to talk about monotherapy Abiraterone, but I do think that the first thing I would do is get that radiation from under your belt, and then you could maybe talk about monotherapy abiraterone and go from there. Yes, quickly, please, Brian Haack.
Sure. So abiraterone is not an ARSI, and it just shuts off any.
It's considered as an ARSI. When we talk about ARSIs, we consider the Ide brothers and abiraterone. That is the general intent today in the literature. It's considered as ARSIs really refer to second-line anti-androgens, androgen receptor signaling inhibitors, and abiraterone's thought to be some type of signaling inhibitor. So it would be in that. It would be in there. Okay.
It's okay. Anyway, that's my comment.
Yeah. So when we talk about ARSIs, or when the literature talks about ARSIs, and there are other acronyms for them, they include abiraterone. Okay. All right. I'm moving along, and next on my list is Richard Fisk.
Okay, a couple of items, quick update. First off, I'd like to thank Dr. Jeff very much for figuratively holding my hand over the last month or so, sorting out what's going on. I thought that I had significant problems coming off prednisone taper after stopping hormone therapy, and it turns out that what was really going on is low iron, which has many of the same symptoms. My iron level is 12, and it should be somewhere between 59 and 158. So I'm getting a iron infusion on Friday, which supposedly will resolve that. The low iron was caused by radiation proctitis, and I saw Dr. Paller on January 9th, and she referred me immediately to Dr. Johnson Arbor, who set me up, and on Wednesday I start 42-hour hyperbaric oxygen treatments to help restore blood flow to the radiation proctitis spot. Testosterone is up to 62 from 0, and PSA remains 0. So that's where I am. And I feel like I'm headed toward good things. Thanks to you folks.
Well, the big issue, the big concern we have with hyperbaric chamber stuff is your eyes. So whoever the doctor is there, definitely review with them whether you need to be concerned about impact on your eyes, because we've seen it before, and it definitely can happen. Anybody else want to say anything about hyperbaric chamber treatments?
Well, the doctor and I discussed the potential impact on eyes, and the fact that I've had cataract surgery in both eyes relieves some of that concern.
Okay. Yeah. That's what. So yeah, maybe you already took care of it. Anybody want to say anything else about hyperbaric treatments? We've had a couple of people that have done them here that I'm aware of. Dr. Mark's done them, a couple of other people, but I know.
Did lots of chamber runs in the Navy, so I'm very familiar.
Yes, that's right. So you know the hyperbaric chamber from your naval days. So yeah, maybe that's why you had cataracts early.
It could be.
Yeah.
That's with lots of bad chemicals in the Navy too. So who knows?
Yeah. Well, talk to Captain Jim to make sure you're getting everything you're entitled to, right, Captain Jim? Show up tomorrow night. You can always make a bit of money off of Captain Jim's sessions. they talk about tariffs. We're imposing a 10% tariff on anything you collect from Dr. Jim's sessions, but we're going to call it a tithe. And if you get 10% of whatever you get from Captain Jim has to be donated from here on out. Listen, if the emperor can set tariffs, I can set tariffs. There you go. So, all right. Anything else on the hyperbaric, or anything else anybody would like to say to Richard? Richard doesn't allow me to use his rank title, so I don't use it. So I just say Richard. So
Well, I left it when I retired.
there you go. Okay, and Mr. Fisk, I can see we don't have any dramatic endeavors coming up because you're totally clean shaven.
That's right. Nothing happening right now. Doing standardized patient, oddly enough, with anemia and a transfusion reaction.
Yeah. All right. I'm going to keep going here because we're getting near the hour. How many more people do I have left? Just to give people a heads up. I think I only have 2 people left. Wow, we're doing pretty good here. Luther and then Jimmy. Luther, are you still with us? Yes, you are. I see you.
Yes, I am, Rick. Just a quick update, guys. I was diagnosed with cancer in 2016, so went through all the prostatectomy and radiation and Lupron therapy and regard. The latest was I was looking for a second opinion. I located and was recommended to another medical oncologist, and primarily because I was dissatisfied with my first primary oncologist due to what I consider to be quality of life issues. So I had that second appointment, went very well. She had reviewed my records and spoke authoritatively about them, made recommendations, and what we concluded was that I had asked my primary oncologist to have a bone scan, which is scheduled, to have a PSA reading, a testosterone, and a bone scan. So those are scheduled for 2 weeks out. And what we also concluded at that second opinion time was that my PSA was 0.03 in October. I'm on a holiday right now. In December, it went up to 0.04. And if it approaches 0.5, she recommended I have options of doing something else, whether that's bone radiation, which my present oncologist says will not work, second generation hormone therapy, which he says I don't need. So I have to make that decision with the outcome of the tests that are coming up. And I think with that knowledge, then I'll know who I'm going to go forward with.
Okay, so can I just clarify a couple of things? Is your PSA 0.3 or 0.03?
0.03.
Okay, so you've got a long way to go. Even at 0.05, you've still got a long way to go. And if I'm not mistaken, you're seeing the same lady as Bob S. Dr. Guanciale, correct?
Correct.
And did you like her?
Absolutely. Absolutely.
Yeah,
Very,
she's one of our stars.
Very patient.
Yes, she's one of our stars, and we love sending people to her because she always gets a 5-star review, and she's just wonderful. She's compassionate. She's wonderful, and we're so appreciative. She takes care of our guys especially, and so we're very grateful. But I think that from our experience here, we don't see docs really intervening until we get a little higher than certainly 0.1, 0.15, somewhere around that, where I'm sure that's probably where she'd be looking. But in terms of, you probably do need a bone scan. Have you had a PSMA scan anytime recently?
No, not recently, a year ago.
Okay, so some of these scans will indicate where you go next. But stick with Dr. Guanciale, and she won't see you wrong, right, Bob Schwartz? He switched off.
No, yes, she is phenomenal. I'm happy to have her as a quarterback, and I appreciate everything you did, Len did, and everybody else did to make sure I got somebody to be my quarterback. Thank you.
Okay. So, is there anything you'd like to ask the group, Luther?
No, not at this point. I think everyone, the messages that I've received so far have been very worthwhile. So I appreciate that from everybody.
Okay, and she's happy to leave you on this drug holiday, right?
She is. She gave me that option. She can go with her, can stay with my present one, or she can consult with me as required.
I switched to her quick. Before she closes out and she can't take any more patients, make sure you get on her list quickly. That's our take home message from her. And last but not least today, and we're not doing bad because with all these people we're only 1 minute over. I think last but not least, but our check was Jimmy's talking. Jimmy.
Oh, it's nice to you got through everybody really fast. It's true. I never thought there was a chance. I'm not going to take much time, but here's my situation. So after a radical prostatectomy in 2019, after a AUS insertion in 2021, the radiation I went through, it has been an adventure down in the groin area, and I'm trying to solve the problem that I had with recurrent favors, which the last diagnosis was when I had a hospital stay last year with cellulitis, but nobody's too sure about that. I have a urologist that's kind of on the case now. He wants to solve by perhaps taking out the AUS. But in the meantime, I got another scrotal ultrasound. This is the third one I've had in 4 years. And I'm here to report that I have big balls. Now, I know what you're thinking. Tell me something I don't already know about Jimmy Greenfield. However, this is not the good kind of big balls. I have a very large hydrocele on my right testicle and a smaller one in my left testicle. So my swelling, a constant swelling, is probably more due to that. I'm wondering how I could have had hydrocele during all this time. Maybe I didn't. Maybe they developed later. But with all of the looking around and poking around and go to ultrasounds and everything else that was done, I don't know. But here they are. And he wants to do surgery to remove the right one. And then the left one, which is smaller, is also on the side where the AUS tab is. The swelling has made it hard for me to access that AUS tab. You guys that don't have an artificial urinary sphincter, you don't even need to pay attention to this because you probably never need it. But Dr. John knows. But anyway, the thing is he says in his notes, and I'm going to see him once before the surgery is already scheduled for February 28th to remove the hydrocele, the right one. But he says the left hydrocele was smaller, and in my experience, there may be a need to consider the risk versus the benefit on that side. So I'm going to ask him, but if any of the doctors or anybody who would know such things have an idea or an opinion of why removing the larger hydrocele on the right side would not also be accompanied by removing the smaller one on the left, and why doing so would constitute a greater risk. Risk of what? I'll ask him what he means, but I just thought it'd be an open question.
So before I go to Steve L., who has his hand up, do any of the docs want to take a shot at that one?
I think what they mean by that wording is that the one side really needs to be done and the other side might not be necessary.
Okay, Dr. Jeff?
Yeah, Jimmy, is there a reason they just won't drain that big hydrocele as opposed to operating on you?
Yeah, the medicine seems to be that it's a temporary solution, and that within some months the hydrocele fills with fluid once again, and that the only defendable long-term solution is to remove it. surgically. That's what I understand.
Can one of you docs, for the benefit of us plebeians here, explain what a hydrocele is, please?
Wait, I'm sorry, I didn't do that.
It's a fluid-filled sac around the testicle.
Okay. And is it peculiar to the testicle, or do other organs get it too?
Testicle.
Okay. Which in that case probably explains why things would get bigger and smaller down there as well, because that fluid is not constant. But thank you. Go ahead, Jimmy.
I'm just concurring. Big balls, I tell you, big balls, man. I wish it was good news, but they're.
How large is the big one? Biggest.
It's big. It looks like there's something a little bit maybe bigger than a golf ball inside my right testicle, or about Dr. Jeff, like, that's not so big, pal.
Well, I've seen guys with oranges.
Yeah. I don't have an orange.
Not
I better
golf
stop
balls.
bragging about my big balls, I guess.
Yeah. So if I were you, again, if I was in your shoes, I might try one drainage before the instead of the operation, because yes, you're 100% right. Hydroceles that get drained often come back, but not all the time. So maybe you're the lucky guy where they put a needle in. I mean, draining a hydrocele takes 10 minutes as opposed to operating on you, cutting your scrotum, removing it, recovery time. It might be worth it, just to try a drainage and see if it works. If it doesn't work, then they can operate.
Thank you. That is a very interesting thing you say, because the thing I get concerned about, as we all do as we get older, is multiple surgeries in the same area. My brother's a 79-year-old doctor. He needs his knee replaced, both of them. He doesn't want to do it because he's worried about anesthesia, and he's a healthy guy. So yeah, we keep going down there and getting in and going under and having surgeries in the same area.
Jimmy, let's see what Steve L. and Richard Fisk have to say.
Please. Yeah.
Steve L. first.
Okay. Yeah, I had a tennis ball size hydrocele removed in the early 2000s. It was successful, didn't have any problems with it. Although it's my understanding that the operation is not always successful. There's often reoccurrence or other problems that can occur. But I didn't have any problems, and it went well for me.
Thanks, Steve. Richard Fisk.
Jimmy, I take your point about repeated surgeries. I had a communicating hydrocele probably 30 years ago, about as big as my fist. And the surgery was not pleasant, but it wasn't that bad. And they left the incision open, and I just drained blood into the shower for a week or two. And that was it. No problems of that sort since.
Thank you.
Thanks. And Dr. Jack.
Yeah, let me make a comment about the anesthesia. You say you're concerned. Believe it or not, 22 years ago, I had a radical prostatectomy done with the spinal anesthesia. It was, great to go through it that way. And if you're going to have a hydrocele done, which is so much, less radical than what I went through, by all means, just find an anesthesiologist who's willing to do a spinal. It's simple. There's no nausea. There's no side effects afterwards. You feel very alert afterwards, and it made a huge difference. So I would look for an anesthesiologist who's willing to do that rather than a general anesthesia. Anything you're going to have done in your pelvic area.
Thank you.
Yeah.
One thing's for sure. I'm going to stop advertising about my big balls, because you guys are talking about oranges and tennis balls. I'm going to keep that out of the conversation now. I can't compete.
That's good. That's a good thing. And remember, if you go for the aspiration, and I probably don't have to say this, but tell the doctor not to forget I would have sclerosing material injected after they pull out the fluid so that it doesn't come back and you don't have to undergo surgery.
Still might come back though, even after
It,
sclerosing.
it could, but
Sclerosing.
yeah, it's a fluid they put in that'll cause the sac to adhere and not allow fluid to fill back.
Okay. Like super glue, right?
Similar.
I think it's doxycycline, isn't it? One of them.
Oh, okay. Very informative. Thank you, gentlemen, very much.
Okay. And by the way, Jimmy's back with his old band. He's the new man in his old band. He's really the old new man in his new band. And Gary N said he was going to come see you. So anybody else who is in the DC area, you can write to Jimmy or write to me and I'll pass it on and he'll keep you apprised of where they're performing and when they're performing, because he's worth watching. I've been there. I've seen it. Been there, done that. So, yes, very much. Oh, we have a third Gary in the meeting. I wonder who the third Gary is. Somebody who came in late. Oh, no, that Gary just left. Well,
There's a guy that I don't recognize, Rick, who came in late. If he's a new guy, I just wanted to say hello and encourage him to come back next. Are you a new guy, Rick, that hasn't been here before? Rick McCollum?
you're muted, Rick. Unmute.
One other time.
Oh, one other time. Okay.
Okay. And did we do an intake on you, Rick, or not?
I think so. I think.
I'm not sure, but sorry that we couldn't get you. But as you can see, that's why if you get our reminder, that's why we ask people to come in early, so that because that way we can time everything.
No, I sit in on the veteran. I'm a veteran Air Force, and you sit in on that one, so I know you from there.
Okay, well, that's probably where I've seen you, but come on back to this one next week, and we'll make sure you get time as a new gent.
Okay, I don't know. I have prostate cancer, but I'm not sure if some of this stuff I don't
Okay.
even know. I've never heard of. So
Okay, so hold on a minute and let's make sure you get to the right group. Have you been treated for your prostate cancer?
yes, it was almost a 6, and I had this I was diagnosed, and they did 12 biopsies.
Okay, so I don't want to get into it right now, if you don't mind. I just want to make sure you get to the right group. What sort of treatment did you have?
I had radiation therapy, and I finished that at the end of November of last year. And now I've been doing hormone therapy, and I get my last shot in March.
Okay, and how long was the total hormone therapy for?
It's been for 2 years.
Okay, so yes, this is the group. Come on back here, and we will handle you next week. And you have questions on recovering from the hormone therapy?
Well, no, I don't know, but I know that it's extreme. I have extreme hot flashes.
Okay, so we'll help you.
We'll
We'll help you next week. Okay.
Okay, sounds good. Thank you.
Because we can help you now, but people are dropping like flies, and I think it's getting late. So we're already 15 minutes over. So come on in next week.
Okay.
Ben will help you. We'll take a history, and Ben will help you. Anything else? Anybody else here? Anyone urgent? Anything urgent?
I gotta say this. Len wanted my impression of you, and that's on the way. when we have time, I saw that on the replay. He was asking
Yeah, he
about my
did.
impression of you.
Yes,
Of you.
but Len's not here tonight, so
I
don't
know,
do
that's
it
why I
again.
didn't pull it
Otherwise,
out.
he'll
I'm
be
waiting for it.
pissed off.
I'll
Len's
wait
not
till he's
well.
here.
Len is not well. He thinks he might have COVID. He came to tell us that at the beginning. Okay. All right. Thank you very much. We'll be back next week on Tuesday at 6 o'clock. And see you all then. Good night, everybody.
Good night, Rick.
Good night.
Thank you.
Yeah, good night, everybody. Good night.